Welcome to this explainer. Today, we're going to completely dismantle that pesky imposter syndrome that's keeping incredible LPNs, RNs, and NPs from taking the leap into health information management, or CDI. If you've ever looked at a healthcare data role and thought, man, I belong on the floor, not behind a spreadsheet, well, you are exactly in the right place. Let's get into it.
Look, let's start by just acknowledging that very real apprehension. Stepping away from the bedside to look at charts and data all day? It can feel like stepping onto another planet entirely. It's completely natural to look at HIM or clinical documentation integrity and worry that you just don't have the quote-unquote perfect background. But we're going to reframe that fear right now, because the reality, your clinical experience isn't a limitation keeping you out. It is literally your most irreplaceable asset. It's the exact competitive edge these data teams are desperately searching for. Because, let's be honest, you simply cannot fake clinical intuition. So here's the crucial point. CDI isn't just a coding job. It's actually clinical storytelling. Think about it for a second. A code might just say pneumonia, but your nursing brain instantly knows the massive difference between a simple infection and a complex, high-risk aspiration pneumonia, right? Your job in CDI is using that deep knowledge to ensure the patient's true complex reality is actually captured in the data. You already know the language.
Section 1. Rethinking coding and sec.
The biggest hurdle is usually this fear of, oh, I don't know medical coding, I'm going to drown in all the rules. But here's the reality check. Coding guidelines, they're just rules. They can absolutely be learned on the job or through a prep course. But your clinical intuition, your ability to scan a chart and instantly know a patient is crashing, that takes years to build. You bring that to the table from day one. Coding is really just the new language you'll use to express what you already know. And let's go ahead and reframe that whole fear of technology too. You really don't need to be a software engineer or a data scientist. EHR queries and dashboards are built for clinicians, not programmers. If you can navigate a clunky medical record system during a hectic 12-hour shift, you can absolutely learn CDI software. Technology is just the vehicle here. Your clinical reasoning is the engine. You might not even realize it, but you're already doing data analytics every single day in your nursing practice. When you're tracking vitals, spotting a slight shift in a patient's breathing, and recognizing that pattern of early sepsis, that is pure analytics in action. In CDI, your core skill is simply looking at information and asking, does this make sense? You've been doing the hard part your entire career. Moving right along to Section 2, valuing your unique background. Now, a lot of folks worry, I've been away from acute care way too long, I've forgotten all those med-surg details. Well, let's flip that script entirely. CDI is not just for ICU veterans. It actually requires a massive, systems-level view of healthcare. And frankly, clinical details can be refreshed so much easier than systems thinking can be taught. It's exactly what CDI teams are hungry for. Whether you come from psych, community health, outpatient care, or case management, you see the patient way beyond the hospital walls. You understand how social determinants impact health, or how chronic diseases evolve over years and years. You know exactly where the ball gets dropped during care transitions. That broad, holistic lens, it makes your documentation accuracy incredibly sharp across the entire continuum of care. Next up, Section 3, a new kind of advocacy. Let's tackle an emotional hurdle here, the apprehension that you'll miss that direct patient connection and feel disconnected from why you became a nurse in the first place. But listen to this. You are not stepping away from patients. You are stepping up to advocate for them in a totally new way. At the bedside, you advocate physically. In CDI, you advocate structurally through your queries. You are fighting to make sure the medical record actually reflects the sheer severity of what they are surviving. Your voice still matters immensely. By ensuring the system recognizes the true complexity of their condition, you directly impact quality scores and secure the right resources for future care. Your impact doesn't disappear, it multiplies. Instead of helping one patient right in front of you, you're improving the system for hundreds, if not thousands of patients at once. Which brings us to Section 4. Your license is your ticket.
Finally, let's address the credentials gap. It's so easy to feel like other candidates might be more qualified on paper. But here's the secret. Critical thinking, clear communication, and clinical assessment absolutely cannot be learned in a weekend certification course. No way. Employers know they are hiring your brain, your curiosity, and your grit. They can teach you the rest.
Check out this timeline. The actual journey usually looks like this. Your nursing license is your ticket in on day one. It proves you can learn complex systems. Then, over your first few months, you learn the software and coding rules on the job. Specialized credentials, like becoming a certified clinical documentation specialist or earning a CDIP, those are just details you can earn later during your first year.
The bottom line I want you to take away from this explainer is that there is no wrong nursing background for CDI. Healthcare data is desperate, literally desperate, for nurses who understand the why behind the care, not just the what. Whatever specialty shaped your unique clinical lens, it is exactly what makes you so incredibly valuable. Trust your foundation.
Now, let's put your nursing knowledge to action with a chart review.
All right, welcome to this explainer. Today, we're diving headfirst into the highly technical and honestly sometimes overwhelming world of chart reviews. We're going to break it down into clear, actionable strategies that you can literally apply today. Look, whether you're navigating the weeds of clinical documentation, abstracting data for quality measures, or just trying to bridge that massive gap between health plan initiatives and super busy provider practices, having a solid roadmap is absolutely essential. So, we're taking a deep dive into the best practices that separate a simply reactive review from a proactive, genuinely value-driven strategy.
So, let's kick things off with a pretty foundational question. What is the actual true purpose of a chart review? Well, it really depends on the lens you're looking through, right? Because a chart review is either about proactively capturing clinical complexity or it's about retrospectively validating quality. If your goal is to ensure a patient's risk adjustment factor, their RAF score, is perfectly accurate, well, you're conducting one specific type of review. But if you're validating that a quality measure was met based on strict specs, you're doing something entirely different. Understanding this why is absolutely the first step to mastering the how.
To navigate all of this, here's our roadmap for today's explainer. We'll start with CDI versus HEDS chart reviews, then hit CDI chart review best practices, followed by the HEDS chart review process. After that, we'll cover the ethical boundaries and queries, and finally wrap up with collaborating for provider education. Let's jump into Section 1, CDI versus HEDIS chart reviews.
Now the line between these two, it's like night and day. Outpatient CDI is all about the now, or even the future. You're asking questions to capture accurate risk adjustment prospectively or concurrently. You're looking holistically for clinical gaps. HEDIS, on the other hand, totally different beast. It is strictly a retrospective audit of quality measures from the past measurement year. It's rigid, rule-driven, and hyper-specific to the measure. In CDI, you're going to send queries to providers to clarify any ambiguity, but in HEDIS, you abstract exactly what is written on the page. No assumptions, and definitely, absolutely no queries.
Moving right along to Section 2, CDI chart review best practices.
Okay, picture this scenario. You're prepping for an annual wellness visit for a specific patient. She's a 68-year-old female, history of diabetes, hypertension, and stage 3 chronic kidney disease. As a CDI professional, your clinical eye is scanning for the complete story here. You aren't just hunting for a single data point. You're looking at her whole problem list, her meds, her recent labs from the last 12 months. You want to see if the documented diagnoses actually reflect how clinically complex she is today.
So how do we actually connect those dots? You've got to follow these exact steps. Step 1 is that pre-visit prep we just talked about. Step 2 is identifying the gaps. For example, maybe you notice, wait, she takes insulin and metformin, but the chart just casually says diabetes. Or you see a recent eGFR of 45, but the problem list just vaguely says CKD without staging it. That leads directly into Step 3, drafting a proactive, compliant query asking the provider to clarify. Is it type 1 or type 2? Are there complications? And finally, Step 4 is your post-visit review to ensure those diagnoses were actually added with the right specificity to impact the HCC capture. All right, switching gears completely. Section 3, HEDIS chart review process. So, contrasting scenario here. Let's say you receive an audit request for a 55-year-old female member, and it's specifically for the HEDIS controlling high blood pressure, or CBP, measure. The measurement year is over, done, and you just need to review her past records. We are no longer looking at her whole patient history or risk scores. Now, we are surgically searching for one specific metric from that measurement year. Now look closely at these steps. Notice what's glaringly missing? Yep, zero querying. You do not ask the provider anything. Step 1 is simply knowing the specs. For CBP, it has to be the most recent blood pressure reading taken by a qualified provider. Step 2, locate all the outpatient visits.
Step 3 is abstraction. If you find a reading of, say, 136/82, you verify it meets the less than 140/90 criteria and you abstract the evidence exactly as it is written. Then, step 4, you mark it as met and submit. If it was high, you'd mark it not met. You are literally just recording the facts exactly as they existed.
This brings us to Section 4, Ethical Boundaries in Queries. Because CDI relies so heavily on provider queries to close those gaps, we have to establish the ethical guardrails. This quote illustrates the gold standard from HIPAA perfectly. A good query does not tell the physician what to document. Let me say that again. It does not tell them what to do. A CDI educator is there to facilitate accuracy, not to prod or push a doctor into a specific diagnosis just to grab higher reimbursement. Your job is to present the clinical indicators that are already in the record and respectfully ask for the provider's medical interpretation.
Look, we've got to treat these ethical rules as empowering boundaries. Ethical best practice means you offer clinically reasonable multiple choice options, and you always include options like other or unable to determine. On the flip side, what's a major compliance risk? Letting financial pressure dictate your queries. If leadership is pushing you to find documentation for a higher weighted code based on finances and not clinical evidence, hard pass. We have to clearly communicate to providers that our one and only goal is accurate documentation that reflects the care they actually provided, whether that means identifying undercoding or overcoding.
I really want you to keep this powerful concept in your back pocket. Ethical boundaries are not barriers to education. They are the literal foundation of trust. Think about it. If a provider thinks you're just fishing for revenue, they're going to completely disengage. But when you consistently stick to written, standardized policies, you're showing integrity. And without that trust, you're never going to successfully change your provider's documentation habits in the long run.
So, are you ready to transition and leverage your nursing knowledge? Our 3-step Nursing Career 2.0 blueprint is designed to help nurses strategically rethink their careers and then develop a targeted plan and toolkit to rebrand and rewrite their professional future. You will gain firsthand knowledge from nurses who became subject matter experts in informatics, medical coding, clinical documentation integrity, innovation, data analytics, project management, and entrepreneurship. Let's start with Section 1 of our Nursing Career 2.0 Blueprint, the Transition Coaching Program. This first step provides the foundational coaching and structure framework to strategically rethink your career path, moving from uncertainty to a clear vision. Now let's look at Section 2, Transforming Clinical Skills into Business Assets. The second step equips you with the specific methodology, like the Clinical Analyst Skill Translator, to rebrand your expertise by reframing clinical skills into strategic business language. And lastly, Section 3, the Strategic Portfolio Advantage. The final step focuses on execution, guiding you to rewrite your professional narrative by building a tangible portfolio with project plan templates that serves as an evidence-based toolkit for your career launch. For ongoing support, we offer our monthly Saturday workshops to help nurses develop their dynamic professional portfolios. Schedule a free consultation today